And so we'll move on to Tim's talk about extra-articular deformity for the distal tibia.
Extra-articular distal tibia osteotomies. Our learning points over the next 10-15 minutes, I want you to appreciate the importance of the clinical exam relative to the ankle here. I'm going to hopefully go over a strategy for managing the fibula in these osteotomies. And then we're going to go through 4 cases that will hopefully give you some examples of what can be achieved relative to distal tibial osteotomies. So not unlike the hip and the knee, which we've already gone through, physical examination is super important. Relative to the ankle, though, range of motion is important to look at, especially, obviously tibio-talar, but especially subtalar. Oftentimes we're correcting either varus or valgus, and knowing whether that subtalar joint has enough motion to compensate for the position that you're going to be putting the distal tibia in now is important to assess beforehand. Sometimes you need to add a calcaneal osteotomy to that to be able to make sure that the foot is coming down flush to the ground. Viewing the patient both from the front and the back gives us a good understanding of what the clinical deformity is. Watching them walk just the same as with your other knee and hip deformities. But then with regards to the ankle, sometimes we can have a deformity that is brought on because of weakness, either in the posterior tib or the peroneals. And so assessing motor strength is important around the ankle. The ankle joint is a complex joint. You see it here with its complex articulations. It's interesting that despite all of these articulations, it still has only 1/3 the contact surface area as what the hip or the knee has. And so this is going to transmit the same force as the hip and knee, just through a smaller surface area, so much more prone to wear out. It has a complex motion. It's not just a simple hinge, but externally, your foot externally rotates as you dorsiflex and internally rotates as you plantar flex. The blood supply is actually quite good in this area, allowing us to be able to do our osteotomies and oftentimes get this to heal. The great majority of the time, we're going to be doing our osteotomies on the medial side of the ankle, either an opening or a closing wedge, sometimes a dome, rarely on the lateral side, although there are times where we need to be on the lateral side. The lateral side makes it a little bit more challenging just to protect our soft tissues, given that the fibula is there. So it can be a little bit more dangerous, I guess. It's important to look at your soft tissues and where previous incisions are. This particular area of the body does not tolerate small skin bridges. And so sometimes we're forced to, because of previous incisions, we're forced to make our incision in a little bit different place than we might want to, or may force us to do our osteotomy in a little bit different location than what we might want to. Typically, we're going to, anything with a 10-degree deformity or more, we're oftentimes going to be cutting the fibula and allowing it to essentially float or move with that distal tibia fragment. The one exception to that is a varus alignment with a widened ankle mortise. So we see the widened ankle mortise here, and by leaving the fibula in place in doing our osteotomy, our valgus osteotomy, or taking it out of varus, we actually reduce the ankle mortise at the same time and improve the overall symmetry of the ankle mortise. So Brett showed this slide earlier. The mechanical axis has been everything through the whole course and will always be that. It's important to know what the norms are. So for the distal tibia is in the coronal plane is about 90 degrees, in the sagittal plane 80 degrees. All right, so let's go through 4 cases here. This is a 25-year-old female who had a previous tibia fracture about 10 years ago. She comes in complaining of knee pain. Here's her x-rays showing her tibia is well healed. Her mechanical axis is not that far off, but when we go ahead and watch her walk, she turns her injured side, turns her knee internally rotated significantly when she's walking. When we put her prone and flex her knees up, her foot the position of her foot is externally rotated, and clinically it's about 20 degrees. And when we get our CT scan, that's confirmed on the CT scan that she has about a 20-degree external rotation of her at her tibia, or mostly at her tibia. I just want to real quick, we've talked a couple different times in the course as to how we verify that we're actually getting the rotational correction that we want to when we're in the operating room. And I'll just give you a little bit of my pollution or my technique of how I like to confirm my rotational correction. So a pin, I use a 2.5 Chance pin, and I do not use these as joysticks. These are strictly for assessing the alignment. One in the proximal fragment, one in the distal fragment, a third pin in the distal fragment. And I like to use my triangle there because this way I'm not trying to sight all the way down the leg, but just right there by the other pin, I can go ahead and accurately judge my correction. And then once my 3 pins are in, I can do my osteotomy. And then when I internally rotate in this situation, the tibia, the anterior pin, which was originally lined up with that proximal pin, now the posterior pin lines up with that proximal pin. And that way I know that I've gotten my correction. And I think it's just a little easier than trying to sight in the triangle all the way down the length of the tibia. So that's what this looks like. Here's our 2 pins distally. We did a transverse osteotomy here, relatively simple, corrected her 20 degrees, internally rotating her. This is her initially post-op and not her healing. Here is her pre-op and post-op mechanical axis, and we actually improved her mechanical axis slightly back more to normal, although it wasn't off that much. And here she is prone with equal symmetry, and here she is walking. Nice result. This one, second case, 13-year-old with a Salter-Harris growth plate injury, treated here with a cannulated screw. This goes on to heal and the screw is removed, but he's developed a Physeal bar across that medial aspect of his physis. An attempt was made at trying to remove the bar with cranioplast put in the defect. Unfortunately, he continued to develop his angulation here at about 80 degrees, or I'm sorry, a 10-degree deformity with a distal tibial angle of 80 degrees. And so the decision was made. Actually, if you look at this image here, you can start to get that sense of this widened ankle mortise here on the medial side. We ended up leaving his fibula intact, and unfortunately we probably had Johnny running the C-arm this day because we didn't get any of the images that we saved. But doing an opening wedge osteotomy of his distal tibia, allowed us to not only, and leaving the fibula, not only correct his overall deformity, but also make his ankle mortise a little more symmetrical. So here's our correction, distal tibial angle of 90 degrees now. And you see his ankle mortise actually looks much more symmetrical overall. Here he is with his hardware out. Case number 3, this is a 24-year-old with congenital valgus ankle. So she has about a 20 degree, almost a 20 degree deformity here. This patient was initially treated by one of my partners who did a closing wedge osteotomy of her distal tibia. And this is his initial post-op x-rays here. And when we draw lines, we see that actually it was somewhat overcorrected, both in the coronal plane and in the lateral plane, or in the sagittal plane. In the sagittal plane, it's almost, he's imparted almost a 15-degree deformity here of her distal tibia. She ended up not healing and breaking her plate, and this is where I was asked to help out. And we took, obviously, the non-union here, the opportunity to try to improve that alignment. This is our post-op alignment, and it's not perfect, but it's much closer to our population norm here. This goes on to heal, and she just recently had her plate out, and she's been pretty happy with this. All right, last case. This is a 65-year-old religious minister who is quite active. He rides his bike about 1,500 miles a year, loves playing basketball, especially in their with the kids in the youth church league. About 8 weeks prior, he had some surgery of his ankle and states that he's been having pain ever since. He comes in to see you and states that he doesn't really feel like he can trust his ankle now. His weight-bearing films in the office are these here, and you see the talus subluxing out front of his ankle mortise. In the office that day, I did some stress views and was able to reduce his talus back into the mortise, but obviously not stable. After the office visit, we were able to get his pre-op x-rays, and you see those here, this large osteophyte on the front, which was really the only thing that was sort of capturing his talus and keeping the front door closed, if you will, or keeping the talus back in the ankle mortise. When you compare them to the stress view that I did that day, you can see the resection, a relatively aggressive resection that was done of the distal tibia, making the ankle joint unstable. So looking at his, quote, normal side, his opposite side, which he also has some arthritis there, he has a relatively normal sagittal plane on his normal side at 80 degrees. His opposite side, or his side now that he's having a problem with, because of the aggressive resection, now has essentially an inclination of his plafond of about 10 degrees more. Our thought was that maybe, because given his joint space here, his joint space actually looks quite good, we might be able to do a osteotomy and try to move the plafond back up over the talar dome. So we decided to do a posterior closing wedge osteotomy of about 15 degrees here, using 2.0 drill bits as our guides, and then our osteotomy with the wedge removed. We cut the fibula to allow it to float with the distal fragment, preliminary fixation, and then our initial fixation after surgery. This is our correction. I wanted to get just a little bit more than neutral on him in an effort to hopefully keep the talus from escaping out the front of the ankle mortise. I also added an external fixator so that with a tibial pin and a calcaneal pin, our vector would be pushing the talus back into the ankle mortise. In an effort to try to do a little bit of a distraction arthroplasty of his ankle joint itself, we added some traction during his office visits. We took the fixator off at 6 weeks, and honestly, I had a fair amount of chest pain when I saw this lateral here, wondering if we were ever going to be able to keep this talus back in the ankle mortise. But at 8 months, he's settled in nicely. Here he is at 2 years. And we tried to get him back in, but he's now 70 years old, has not had any more surgery on this ankle, and doesn't really want to come in just because of the virus right now. So in conclusion, I think it's really important, especially the ankle, because of most of our osteotomies being either in the coronal plane, looking at subtalar motion and making sure that the subtalar joint can compensate for whatever position you're putting the distal tibial fragment in. Most angular corrections can be done from the medial side, and that makes it much easier to protect the soft tissues. Fibular osteotomy for anything over 10 degrees and allow that fibula to stay with that distal fragment and seek its position. And then, like so many of the other osteotomies, right, restoring normal anatomy, oftentimes the patients end up with a significant improvement, if not a great deal of improvement. So